Describe your process for calculating and verifying pediatric medication dosages, particularly for high-alert medications. What specific checks do you perform to prevent errors in the pediatric population?
My process for calculating and verifying pediatric medication dosages, especially for high-alert medications, is meticulously structured to prioritize patient safety and prevent errors. Firstly, for any pediatric medication, the foundational step is always confirming the patient's current weight in kilograms, as nearly all pediatric dosages are weight-based. I then retrieve the physician's order and proceed with the calculation, paying close attention to the ordered dose per kilogram, the drug concentration available, and the desired final volume. I perform these calculations methodically, often writing them out and double-checking each step, ensuring the units are consistent and correct. For high-alert medications, my verification process is particularly stringent. After my initial calculation, I immediately engage in an independent double-check with another qualified registered nurse or, if available, a pharmacist. This involves both of us independently calculating the dose from the original order, comparing our results, and then verbally confirming the drug name, concentration, calculated dose, volume to be administered, route, and rate. We always cross-reference the prescribed dose against reliable pediatric medication references, such as hospital formularies or specialized drug guides like Harriet Lane or Lexicomp, to ensure it falls within a safe therapeutic range for the child's age, weight, and clinical condition. Additionally, I utilize available technology such as smart pumps with dose error reduction systems, which provide a critical safety net by alerting to any programming outside safe parameters. I also verify the 5 rights of medication administration, the right patient, drug, dose, route, and time meticulously. I also check for the right indication and any potential drug interactions or allergies. Any ambiguity in the order or calculation prompts immediate clarification with a prescribing physician before administration. This comprehensive, multi-layered approach is crucial for minimizing risks in this vulnerable population.
How do you approach administering oral medication to a toddler who is refusing to take it? What strategies do you employ to ensure compliance while minimizing distress?
Administering oral medication to a toddler who is refusing can certainly be a challenge, and my approach focuses on a blend of calm persuasion, strategic techniques, and minimizing distress to ensure compliance. Firstly, preparation is key. I ensure I have all necessary supplies ready, including the medication in the correct dose using an oral syringe or dropper, a small amount of palatable chaser drink, and perhaps a small reward. I always try to approach the child in a calm, reassuring manner, avoiding any sense of urgency or confrontation, as toddlers are very sensitive to adult emotions. I then try to empower the toddler by offering limited, age-appropriate choices, such as, do you want to take your medicine with a spoon or a syringe? Or would you like water or apple juice afterwards? This gives them a sense of control over the situation, even if the ultimate decision to take the medication isn't theirs. I briefly and honestly explain that the medicine will help them feel better, without giving too much detail that might overwhelm them. During administration, I aim for quick and efficient delivery. If permitted and compatible with the medication, I might mix it with a very small amount of a preferred liquid or soft food like applesauce, ensuring the entire dose is consumed. When using a syringe, I administer the medication slowly into the side of the mouth towards the cheek to prevent gagging and allow the child time to swallow each small increment. Immediately after, I offer the chosen chaser or a small, tangible reward like a sticker or a favorite toy. It's crucial to acknowledge their feelings throughout the process, saying something like, I know you don't like this, but you are doing a great job helping yourself get better. If the toddler is highly distressed, I prioritize safety by ensuring they are in a semi-upright position to prevent aspiration. Ultimately, my goal is to make the experience as positive and least traumatic as possible, building trust and encouraging future cooperation.
Discuss your experience with various pediatric 4-access methods, e.g., peripheral, central lines, interosseous, and the unique considerations for maintaining these in children.
Certainly. My experience in pediatric nursing has provided me with hands-on proficiency in managing various 4-access methods, each with its unique considerations for the pediatric population. For peripheral IVs, which are the most common, the primary challenge in children is vein selection and successful insertion. Children have smaller, more fragile veins, and anxiety can lead to vasoconstriction. I employ strategies such as topical anesthetics, e.g., lidocaine cream, distraction techniques tailored to their developmental stage, and parental involvement to minimize distress during insertion. Once cannulated, maintaining patency and preventing dislodgement is paramount. I use appropriate securement devices, transparent dressings for easy site visualization, and protective covers to prevent accidental removal during play or movement. Regular assessment of the site for signs of infiltration, phlebitis, or infection is crucial, given children's limited ability to verbalize discomfort. My experience with central venous lines (CVLs), including peripherally inserted central catheters (PICCs) and implanted ports, involves comprehensive care aimed at infection prevention and maintaining integrity. These lines are often used for long-term therapy, total parenteral nutrition, or vesicant medications. Unique considerations include meticulous aseptic technique during dressing changes and lumen access, given the high risk of central line-associated bloodstream infections, CLABSIs. I ensure securement to prevent accidental pulling, meticulous flushing protocols to maintain patency, and vigilant monitoring for signs of infection such as fever or changes at the insertion site. Educating parents on the line's purpose and daily care is also a vital aspect of maintaining these lines in the home environment. Regarding intraosseous IO access, while less frequent, is a critical skill for emergency situations when peripheral and central access is unattainable, particularly in cases of severe dehydration, shock, or cardiac arrest. My experience here focuses on rapid, sterile insertion into the tibia or humerus, confirming placement and understanding the contraindications. The unique consideration for IO lines is their short-term nature. They are a bridge to more permanent access, and the site requires close monitoring for signs of extravasation or compartment syndrome. Across all methods, psychological support for both the child and family, precise fluid balance monitoring, and age-appropriate explanations are integral to successful management and minimizing distress.
How do you adapt your vital sign assessment techniques for infants, toddlers, and school-age children, particularly when they are distressed or uncooperative?
Adapting vital sign assessment techniques across different pediatric age groups, especially when children are distressed or uncooperative, is a cornerstone of effective pediatric nursing. My primary strategy is always to prioritize the least invasive and most critical vital signs first, performing assessments rapidly yet accurately, and integrating distraction and comfort measures. For infants, I aim to assess their respirations and apical heart rate while they are quiet or sleeping, if possible. This yields the most accurate baseline without provoking distress. I observe their abdominal breathing for a full minute for respiratory rate. Temperature is typically taken axillary or temporally to avoid causing discomfort. Blood pressure is generally not routine unless indicated, and if needed, I ensure the correct cuff size and perform it when the infant is calm. If the infant is crying, I'll allow them to be comforted by a parent and reassess once settled, often prioritizing breath sounds and heart rate auscultation first. When assessing toddlers who are prone to stranger anxiety and asserting independence, I adopt a playful and patient approach. I try to perform assessments while they are on a parent's lap, offering simple choices like, "Do you want me to listen to your tummy or your heart first?" I use distraction techniques such as bubbles, a favorite toy, or engaging in conversation about familiar objects. I might explain the blood pressure cuff as a cuff hug for their arm. The goal is to be quick and efficient, moving through the assessment before their short attention span wanes, always ensuring safety and avoiding power struggles. For school-age children, I can provide more direct explanations about why vital signs are taken, fostering a sense of cooperation. I involve them in the process, perhaps letting them hold the thermometer or watch the numbers on the blood pressure monitor. If they are distressed, I validate their feelings, saying, "I know this isn't fun, but it helps me understand how to make you feel better." Distraction remains valuable, perhaps by discussing their favorite activities or school. I prioritize a calm demeanor, allowing them some control where appropriate, which often leads to greater compliance and less distress during the assessment. Across all age groups, involving parents as comforters and allies is invaluable.
Describe how you assess pain in a nonverbal infant or a preschooler. What pain scales are you familiar with, and how do you use them effectively?
Assessing pain in nonverbal infants and preschoolers requires a keen eye for behavioral cues, physiological indicators, and the effective use of age-appropriate pain scales. My approach is comprehensive, always involving observations and caregiver input. For nonverbal infants, pain assessment relies heavily on observing changes from their baseline behavior. I look for specific cues such as facial expressions, a furrowed brow, scrunched eyes, an open mouth square shape, or a rigid grimace. Body movements are also telling, manifesting as generalized stiffness, flailing, drawing knees to the chest, or guarding a specific area. The characteristics of their cry are crucial. A high-pitched, inconsolable, or whimpering cry often signals pain. I also know changes in their sleep patterns, feeding habits, or general activity level, and whether usual comforting measures are effective. Physiologically, changes in heart rate, respiratory rate, blood pressure, or oxygen saturation can be indicators, though these are less specific. The primary pain scale I utilize for infants and other nonverbal children is the FLACS scale: face, legs, activity, cry, consolability. I systematically score each of these 5 behavioral categories from 0 to 2, providing a total score out of 10 that guides my pain management interventions. When assessing preschoolers, while they are still largely nonverbal in terms of describing pain quality or location, they can often point or indicate their discomfort. My observations extend to their play behavior, a sudden reluctance to play, withdrawal, or even regressive behaviors like thumb-sucking or clinging. Facial expressions remain a key indicator, alongside guarding of painful areas, limping, or slumped posture. For this age group, I commonly use the FACES pain scale, Wong-Baker FACES pain rating scale. I explain the scale by pointing to the happy face and stating no hurt, and then gradually moving to the crying face representing worst hurt, asking the child to point to the face that best describes how they feel. This visual tool helps them quantify their pain in a way they can understand. I'm also familiar with the Oucher pain scale, which similarly uses photographs of children's faces. In using any pain scale, consistency is vital. I use the same scale for the same child to track trends and evaluate the effectiveness of interventions. Importantly, I always combine the scale score with my clinical judgment, the observed behavioral and physiological cues, and input from the parents who often know their child's unique pain responses best. Regular reassessment after administering analgesia is critical to ensure the pain is adequately managed.
What are the key signs of respiratory distress in an infant versus an adolescent? And what immediate nursing interventions would you prioritize for each?
The key signs of respiratory distress differ, notably, between infants and adolescents, reflecting their physiological distinctions. Consequently, immediate nursing interventions are tailored to their unique needs. In infants, respiratory distress manifests primarily through physical effort and observable changes. The earliest and often most reliable sign is tachypnea, an abnormally fast breathing rate. This is quickly followed by the use of accessory muscles, evidenced by visible retractions, indrawing of the skin in the suprasternal, supraclavicular, intercostal, or subcostal areas. Other critical signs include nasal flaring, where the nostrils widen with each breath, and grunting, a short, low-pitched sound heard on exhalation as the infant tries to keep airways open. In severe distress, one might observe head bobbing, central cyanosis, a bluish discoloration around the mouth or on the trunk, or paradoxical breathing. Immediate nursing interventions prioritize airway patency and oxygenation. I would position the infant in a sniffing position or with the head of the bed slightly elevated to align the airway, gently suction any nasal or oral secretions, and promptly administer supplemental oxygen via blow-by, nasal cannula, or an oxygen hood, titrating to maintain target oxygen saturation. Continuous cardiorespiratory monitoring and pulse oximetry would be initiated, and I would minimize environmental stimulation to conserve the infant's energy while preparing for potential advanced respiratory support if the distress escalates. For adolescents, while tachypnea is also a sign, their presentation of respiratory distress often includes subjective complaints and more overt signs of increased work of breathing. They can verbalize dyspnea, the sensation of shortness of breath, and might complain of chest tightness or pain. Objectively, they will exhibit the use of accessory muscles, though retractions may be less dramatic than in infants. Audible breath sounds like wheezing or stridor might be present, and they may assume a tripod position, leaning forward with hands on knees to optimize lung expansion. Cyanosis, if present, might first appear peripherally before progressing to central. Other signs include increased anxiety, restlessness, and in severe cases, an altered mental status. Immediate nursing interventions for an adolescent involve positioning them upright for maximal lung expansion, providing supplemental oxygen via nasal cannula, simple mask, or non-rebreather mask as indicated by their oxygen saturation. I would ensure their airway is clear, assess for foreign body obstruction if suspicion exists, and administer ordered bronchodilators via nebulizer or meter-dose inhaler. Continuous monitoring of vital signs, including pulse oximetry, is essential, and I would provide calm reassurance to alleviate their anxiety while preparing for potential escalation of care, such as intubation, if respiratory failure becomes imminent.
How do you integrate age-appropriate play and developmental milestones into your care plan for hospitalized children?
Integrating age-appropriate play and developmental milestones into the care plan for hospitalized children is fundamental to pediatric nursing, as it supports not only their physical healing but also their emotional well-being and developmental progression. My approach begins with a thorough assessment of each child's current developmental stage, considering their typical interests and abilities prior to hospitalization, and observing any regression that might be occurring due to their illness or the unfamiliar environment. For infants who are exploring their world through senses, I ensure their environment provides gentle sensory stimulation. This includes mobile, soft toys with varying textures, soothing sounds, and opportunities for gentle touch and cuddling from parents or caregivers. The care plan emphasizes consistent routines for feeding and sleeping, promoting secure attachment and trust. With toddlers who are striving for autonomy, I incorporate play that allows for choice and exploration within safe boundaries. This might involve simple push-pull toys, stacking blocks, or board books. Crucially, I introduce therapeutic play, using doll play or medical equipment to demystify procedures, allowing them to express fears and gain a sense of control. Providing opportunities for parallel play, even if just with another child in the playroom, helps prevent social isolation. For preschoolers who engage in imaginative play, the care plan includes access to art supplies for emotional expression, puppets, and dress-up clothes for role-playing. Therapeutic play becomes more sophisticated, allowing them to perform medical procedures on a doll, which can significantly reduce anxiety before real procedures. I also encourage simple games with clear rules to foster social development. For school-age children and adolescents, play evolves into activities that support their cognitive, social, and emotional needs. For school-age children, this could mean board games, card games, or puzzles that challenge their thinking, as well as opportunities for social interaction with peers or staff. For adolescents, respecting their need for privacy and autonomy, I facilitate access to personal electronic devices, books, music, and opportunities for social interaction with their peer group, often through supervised common areas or via technology. In all age groups, I collaborate closely with child life specialists, who are experts in therapeutic play and developmental support, to tailor interventions. My care plan also includes educating parents on the importance of continued play and developmental activities during hospitalization, empowering them to actively participate in their child's holistic care. This integrated approach not only distracts from pain and anxiety, but also prevents developmental delays and promotes resilience in the face of illness.
Discuss the developmental differences in how a 4-year-old versus a 14-year-old might cope with a chronic illness. How do you tailor your support for each?
Coping with a chronic illness presents vastly different challenges for a 4-year-old versus a 14-year-old, largely due to their distinct developmental stages. Tailoring nursing support to these differences is crucial for effective care and positive outcomes. A 4-year-old is in the preoperational stage of cognitive development. Their understanding of illness is often magical, concrete, and egocentric. They may believe their illness is a punishment for something they did, or that it is contagious like a cold. Their concept of time is limited, making long-term treatment plans difficult to grasp. Coping at this age often manifests through behavioral changes such as regression, e.g., bedwetting, thumb-sucking, increased tantrums, clinginess, or withdrawal from play. They lack the verbal skills to articulate their fears or discomfort effectively. My support for a 4-year-old with a chronic illness focuses on creating a sense of normalcy and security. This involves maintaining consistent routines as much as possible, using simple, concrete language to explain procedures. This medicine will help your tummy feel better, and employing extensive therapeutic play. I'd use dolls or puppets to demonstrate treatments, allowing the child to act out their fears and gain a sense of control. Distraction during procedures with bubbles, songs, or favorite toys is essential. Most importantly, I collaborate closely with parents, providing them with emotional support and practical strategies, as a child's coping is heavily dependent on the parent's ability to manage their own stress and maintain a calm, reassuring environment. In contrast, a 14-year-old is navigating adolescence, a period characterized by a strong drive for independence, identity formation, body image concerns, and intense peer relationships. A chronic illness can significantly disrupt these developmental tasks. They possess abstract thinking capabilities, meaning they can understand complex medical information, but this also allows for deeper fears about the future, quality of life, and mortality. Coping may involve denial, anger, non-adherence to treatment, especially if it interferes with social life or appearance, social isolation, or even depression. My support for a 14-year-old with a chronic illness shifts towards fostering autonomy, providing honest information, and supporting peer connections. I involve them in shared decision-making regarding their treatment plan, explaining the why behind interventions and allowing choices whenever medically safe. Honest and open communication is paramount. I address their concerns about body image, school, sports, and future implications of their illness. I encourage self-management skills, gradually handing over responsibility for medication administration and appointment scheduling. Facilitating connections with peers who also have chronic illnesses, or ensuring they maintain existing friendships is vital to combat feelings of isolation. Additionally, I actively screen for mental health challenges like depression or anxiety, offering resources like counseling or support groups to help them process their emotions and develop healthy coping mechanisms as they transition towards independent adult life.
You have a pediatric patient admitted with bronchiolitis. Outline your nursing care plan, including key assessments, interventions, and parent education points.
For a pediatric patient admitted with bronchiolitis, my nursing care plan focuses on comprehensive assessment, targeted interventions, and thorough parent education to support recovery and prevent complications. Key assessments. My initial and ongoing assessments center on the patient's respiratory status. This includes frequent monitoring of respiratory rate, evaluating the work of breathing by observing for retractions, subcostal, intercostal, suprasternal, nasal flaring, and grunting. I auscultate lung sounds carefully for wheezing, crackles, or diminished breath sounds, and assess oxygen saturation via pulse oximetry. I also critically assess the child's color for pallor or cyanosis and their level of consciousness, irritability, and activity, as changes can indicate hypoxia. Beyond respiratory status, I monitor hydration by assessing intake and output, mucous membranes, skin turgor, and the number of wet diapers, given that increased respiratory effort can hinder oral intake. Temperature is routinely monitored for fever. Interventions. My priority interventions are aimed at optimizing respiratory function and maintaining hydration. I position the infant with the head of the bed elevated or in a sniffing position to facilitate airway patency. Gentle, frequent nasal and nasopharyngeal suctioning, especially before feeds, is crucial to clear secretions. Humidified oxygen therapy is administered as needed, titrating the flow to maintain oxygen saturation above 90 to 92%. While bronchodilators and corticosteroids are generally not indicated for bronchiolitis unless specific comorbidities exist, nebulized hypertonic saline may be administered if ordered to help loosen secretions. Close monitoring with continuous pulse oximetry and frequent respiratory assessments is paramount. For hydration and nutrition, I encourage small, frequent oral feeds if tolerated, or administer intravenous fluids as ordered to prevent dehydration. Strict infection control measures, including meticulous hand hygiene and isolation precautions, are rigorously maintained to prevent spread within the hospital. Fever is managed with antipyretics for comfort. Parent education. Educating parents is a vital component of the care plan, preparing them for both the hospital stay and discharge. I explain that bronchiolitis is a common viral infection causing inflammation of the small airways, often self-limiting, but requiring supportive care. I teach them to recognize crucial signs of worsening respiratory distress, such as increased work of breathing, more visible retractions, faster breathing, difficulty feeding, decreased wet diapers, lethargy, or any bluish discoloration around the lips or skin, emphasizing that these warrant immediate medical attention. We discuss practical home care strategies like effective nasal suctioning techniques using saline drops and a bulb syringe, the importance of offering small, frequent feeds to maintain hydration, and appropriate fever management. I stress the importance of hand hygiene and avoiding exposure to smoke or other irritants. I also set realistic expectations that the cough and congestion can persist for several weeks post-discharge and highlight the importance of follow-up appointments.
Describe the nursing management for a child experiencing a febrile seizure. What are your immediate priorities, and how do you support the family?
When a child experiences a febrile seizure, my immediate nursing management priorities are centered on ensuring the child's safety, meticulous observation, and subsequent comprehensive assessment and intervention, all while providing crucial support to the often distressed family. During the seizure, my absolute first priority is safety. I would immediately place the child on a flat, protected surface, removing any nearby objects that could cause injury. My focus is on preventing harm, so I would gently turn the child onto their side into a recovery position to maintain an open airway and prevent aspiration, especially if vomiting occurs. Crucially, I would never attempt to restrain the child's movements or place anything in their mouth, as this can cause injury. Simultaneously, I will begin to time the seizure accurately from onset to cessation, observing and documenting its characteristics, such as type of movements, tonic-clonic, focal, eye deviation, color changes, and the child's level of consciousness. Once the seizure subsides, my focus shifts to the ABCs: airway, breathing, circulation. I reassess the airway for patency, ensure effective breathing, and check circulation. If oxygen saturation is low or cyanosis is present, supplemental oxygen would be administered. I then obtain a full set of vital signs with particular attention to temperature, as managing the fever is key. I assess the child's post-ictal state, noting any drowsiness, confusion, or agitation. Fever management is initiated promptly with antipyretics, typically acetaminophen or ibuprofen, administered via a rectal or oral route once the child is fully alert and able to swallow safely. I would remove any excessive clothing to help dissipate heat, avoiding any methods that might induce shivering. A brief neurological assessment is performed to ascertain the child's baseline and recovery, and detailed documentation of the entire event, interventions, and the child's response is completed. Supporting the family is paramount throughout this frightening experience. My immediate action is to provide reassurance, explaining calmly that while terrifying to witness, febrile seizures are generally benign and rarely cause long-term neurological damage or indicate epilepsy. I then provide education, explaining that these seizures are typically caused by a rapid rise in body temperature rather than the fever's height, and that the child's brain is healthy. I guide them on how to respond if another seizure occurs, emphasizing safety measures and the importance of timing. We discuss ongoing fever management strategies, clarifying that antipyretics aim to comfort the child, but do not necessarily prevent future febrile seizures. Critically, I educate them on when to seek immediate medical attention, such as if a seizure lasts longer than 5 minutes, the child does not regain consciousness quickly, or repeated seizures occur. I encourage them to express their fears and questions, offering emotional support and confirming that their feelings of panic or guilt are normal. Providing written information and discussing follow-up with their pediatrician further empowers the family in managing their child's health.
A 7-year-old patient is extremely anxious about an upcoming procedure, e.g., blood draw or insertion. How would you prepare them, using child-friendly language and distraction techniques?
When faced with a 7-year-old patient who is extremely anxious about an upcoming procedure like a blood draw or insertion, my approach centers on building trust, providing honest yet child-friendly information, and employing effective distraction techniques to minimize their distress. My first step is to approach the child calmly and at their eye level, acknowledging their feelings by saying something like, "I can see you're feeling a little worried, and that's totally okay. We're going to do something that helps us take care of you, and I'll be right here with you." I then prepare them using age-appropriate language, explaining exactly what will happen in simple terms. For an insertion, I might say, "We're going to put a tiny soft straw into your arm, and it might feel like a quick poke or a pinch, like a mosquito bite, but it will only last for a super short time. This straw will help us give you special medicine or fluid to help you feel better." I always explain the purpose of the procedure, linking it to their well-being in a way they can understand. If time permits, applying a topical anesthetic cream beforehand is invaluable. I involve the child in the preparation by offering limited choices to give them a sense of control. Which arm do you want us to use? Or do you want it to sit on the bed or on mommy/daddy's lap? I might also show them some of the equipment, allowing them to touch the tourniquet. This is a gentle hug for your arm, or the sterile swab. This is cleaning soap. During the procedure, my primary strategy shifts to distraction. I utilize a variety of techniques based on the child's interests. This could involve visual distraction, having them focus on an I Spy game, watching a favorite cartoon or video on a tablet, or counting the ceiling tiles. Auditory distraction, telling an engaging story, singing a familiar song, or having them listen to their favorite music through headphones. Tactile distraction, encouraging them to squeeze a stress ball, hold a comfort item like a favorite stuffed animal, or blow bubbles, which also serves as a deep breathing exercise. Cognitive distraction, engaging them in a counting game, asking the questions about their favorite movie characters, or having them blow out imaginary candles. Throughout the procedure, I maintain a calm, reassuring tone, offering continuous praise for their bravery and cooperation, no matter how small. You are doing such a great job holding still. Or almost done. You're so brave. As soon as the procedure is complete, I immediately praise them, acknowledge their courage, and offer a small reward like a sticker, reinforcing a positive association despite the temporary discomfort.
You have a child who is refusing to engage in physical therapy due to fear. How do you motivate them and make the therapy session more appealing?
When a child refuses to engage in physical therapy due to fear, my primary approach is to understand the root cause of their apprehension and then to transform the therapy session into an appealing, child-centered experience. Fear in children can stem from pain, the unfamiliarity of the equipment or environment, anxiety about failure, or simply a lack of understanding of the therapy's purpose. My first step is always to build rapport and trust. I spend time getting to know the child on their level, engaging in non-medical conversation about their interests, hobbies, and favorite things. I acknowledge their feelings directly, saying, I can see you're feeling a little scared, or maybe it feels too hard right now, and that's okay. We're going to work on this together, and I'll make sure it feels safe. Involving parents as a source of comfort and familiarity is also crucial, as their presence can significantly reduce the child's anxiety. Next, I employ child-friendly communication to explain the why behind the therapy in simple, relatable terms. Instead of clinical jargon, I might say, this exercise will help your leg get stronger so you can run and play soccer again, or we're going to make your arm really good at drawing pictures. I often demonstrate the exercise on myself or a doll first, allowing them to see what it entails. To make the therapy session truly appealing, I integrate play-based strategies to gamify the exercises. This is where creativity is key. Instead of simply lifting a leg, we might be kicking a monster away or marching like a soldier. Exercises can be incorporated into obstacle courses, where crawling through tunnels, stepping over foam blocks, or throwing beanbags at targets becomes part of their therapy. We can use bubbles to encourage deep breathing, reaching, or balance. Depending on their age and interests, I might play their favorite music, incorporate characters they love, or even turn a movement into a Simon Says game. Offering limited choices also empowers them, such as, do you want to do this exercise 3 times or 5 times? Or which game should we play first that helps your arm? Throughout the session, I maintain a flexible pace, offering frequent breaks and ample positive reinforcement, such as high fives, verbal praise, or a sticker chart for completing tasks. The goal is to make them feel successful and in control, transforming a potentially frightening experience into a rewarding and even fun part of their day.
A parent is highly distressed and demanding specific treatments for their child that are not medically indicated. How would you compassionately but firmly address their concerns while upholding professional standards?
When a parent is highly distressed and demanding specific treatments that are not medically indicated for their child, my approach is to balance deep compassion with firm adherence to professional standards and evidence-based practice. My immediate priority is to acknowledge and validate the parent's distress. I would approach them with empathy, saying something like, I can see how incredibly worried you are about your child, and it's completely understandable to feel overwhelmed and want to explore every possible option. We all want what's best for your child. This validates their emotions and builds a crucial foundation of trust, allowing them to feel heard rather than dismissed. Following this, I would actively listen to understand the specific concerns driving their demands. I would ask open-ended questions to ascertain if their request stems from misinformation, desperation, a previous anecdotal experience, or a deep-seated fear. Understanding their perspective is key to addressing it effectively. Then, I would educate compassionately but firmly. I would explain the child's current medical condition in clear, simple, and non-judgmental language, outlining the established, evidence-based care plan that is currently in place. I would gently but unequivocally explain why the requested treatment is not medically indicated or, more importantly, why it might even be harmful or counterproductive in their child's specific situation. I would phrase this by focusing on patient safety and best outcomes, for example. While I understand why you might feel that particular treatment could help, for your child's specific diagnosis, current medical evidence indicates that our current plan is the safest and most effective course of action. Administering X could potentially cause side effects that we want to avoid, or it might interfere with the treatments that are working. Crucially, I would uphold my professional responsibility by stating clearly, as your child's nurse, my primary commitment is to their safety and well-being, and I am bound to provide care that adheres to established medical protocols and evidence. I cannot administer treatments that are not medically indicated or could put your child at risk. I would immediately involve the primary physician in this discussion, offering to facilitate a joint conversation where the doctor can further address the parent's concerns and explain the rationale for the current treatment plan. If necessary, I would suggest involving other members of the healthcare team, such as a social worker or even an ethics committee, to provide additional support and perspective, ensuring a unified and consistent message. Throughout this challenging conversation, I will maintain a calm and professional demeanor, continuously reassuring the parents that the entire healthcare team is dedicated to achieving the best possible outcome for their child.
You discover a parent giving their child an unprescribed herbal remedy on the ward. How do you approach this situation, ensuring the child's safety and maintaining trust with the family?
When I discover a parent giving their child an unprescribed herbal remedy on the ward, my immediate priority is the child's safety, followed closely by maintaining a trusting relationship with the family. My first action is to gently and non-confrontationally intervene to prevent further administration and immediately assess the child for any signs of adverse reaction or interaction. I would approach the parent with a tone of concern rather than accusation, saying something like, "I noticed you're giving child's name something." My main concern is always child's name as safety, and sometimes unprescribed remedies can interact with the medications we're giving here or have effects we're not expecting. Could you tell me what it is? Once I identify the specific remedy, my next step is to educate the parent compassionately but clearly about hospital policy and the potential risks. I explain that in a hospital setting, it's crucial for the medical team to be aware of and approve all substances the child receives, including herbal remedies, vitamins, or supplements. I would explain that unknown ingredients, inconsistent dosages, or interactions with prescribed medications could potentially harm their child or interfere with the effectiveness of the hospital's treatment plan. I would emphasize that our shared goal is the child's optimal well-being, and knowing everything they're taking is essential for their safety. I'd reassure them that I understand their desire to help their child and that I appreciate their openness. Simultaneously, I would immediately inform the physician and pharmacist about the situation and the specific remedy the child received. This allows them to assess for any potential drug-herb interactions, contraindications, or necessary adjustments to the child's prescribed medications. The conversation with a parent, the details of the remedy, and the notification of the healthcare team will be thoroughly documented. Finally, to maintain trust, I would work collaboratively with the parent. If their intention was to relieve a specific symptom, I would discuss the medically indicated options available within our current care plan. For instance, if they were trying to help with discomfort, I'd say, "I understand you were trying to help with symptom. Let's talk about the prescribed medications or other comfort measures we can use that are safe and approved for your child's condition." My aim is to convey that we are partners in their child's care, and by ensuring all treatments are vetted by the medical team, we are collectively ensuring the safest and most effective path to recovery.
A child's parents are divorced and have conflicting views on their child's care plan. How do you facilitate communication and ensure the child's best interests are maintained?
Navigating situations where divorced parents have conflicting views on their child's care plan requires a delicate balance of compassionate communication, clear advocacy for the child, and strict adherence to professional and legal guidelines. My primary goal is always to ensure the child's best interests remain at the forefront. My initial approach involves active listening to each parent separately, if possible, to fully understand their individual concerns, perspectives, and the reasons behind their conflicting views. It's crucial to acknowledge and validate their emotions, as parental distress can often fuel disagreements. I might say, "I understand this is a very difficult time, and it's clear you both deeply care about your child. Let's work together to make the best decisions for them." This establishes an empathetic foundation. Once I have a clear understanding, I facilitate communication by scheduling a joint meeting with both parents and the primary physician, and potentially other relevant team members like a social worker or child life specialist. In this meeting, I ensure the conversation remains focused on the child's medical needs and evidence-based care. I act as a neutral facilitator, ensuring each parent has an opportunity to express their views without interruption, while gently redirecting any personal disputes back to the child's health. The physician will clearly explain the recommended care plan, its rationale, and the potential consequences of deviating from it, emphasizing the benefits to the child. Crucially, I uphold professional standards and legal requirements. I clarify the hospital's policy regarding parental consent, especially if there's a court order defining medical decision-making authority. If no specific court order exists, both parents generally have equal rights. In cases of significant disagreement, or if a parent's demands could potentially harm the child, I immediately escalate the concern to the healthcare team leader, the physician, and potentially hospital legal or ethics committees. My responsibility is to advocate for the child's well-being, which sometimes means navigating complex family dynamics to ensure they receive necessary and appropriate care. Throughout this process, clear and consistent documentation of all discussions, decisions, and concerns is vital. I also ensure that the child's voice, if age-appropriate, is considered and respected within the care planning process, perhaps through conversations with a child life specialist. Ultimately, my role is to create a safe space for communication, provide accurate medical information, enforce professional boundaries, and ensure the child's health and safety guide every decision.
You are caring for an infant who suddenly becomes lethargic and pale, with a weak cry. What are your immediate actions, and how do you escalate this situation?
When an infant under my care suddenly becomes lethargic and pale, exhibiting a weak cry, these are critical signs indicating a rapid decline in their condition, demanding immediate and decisive action. My immediate priority is to rapidly assess the infant's airway, breathing, and circulation ABCs. I would first ensure a patent airway, gently repositioning the head if necessary. I then quickly assess their respiratory effort, rate, and lung sounds, noting any signs of distress like retractions or grunting. Concurrently, I'd check their heart rate, capillary refill time, and skin temperature to gauge their circulatory status. While this rapid assessment is underway, I would simultaneously call for immediate assistance from my colleagues, using the hospital's emergency alert system or calling for a pediatric rapid response team, clearly stating the emergent situation. As help arrives, my actions would continue to focus on stabilization. I would place the infant on a cardiac monitor and pulse oximeter for continuous physiological monitoring. If their breathing is compromised, I prepare for and assist with bag mask ventilation or administer supplemental oxygen via the most appropriate delivery method, aiming to maintain adequate oxygen saturation. Depending on the initial assessment of circulation, I'd anticipate the need for intravenous access to administer fluids, such as a bolus of isotonic crystalloids, especially if signs of shock are present. I would also quickly obtain a full set of vital signs and a rapid glucose check, as hypoglycemia can cause such symptoms in infants. To escalate the situation beyond the immediate call for assistance, I would provide a concise, clear SBAR, situation, background, assessment, recommendation, report to the medical team as soon as they arrive. My situation will be the sudden onset of lethargy, pallor, and weak cry in the infant. The background would include relevant medical history and current primary diagnosis. My assessment would detail the abnormal ABC findings, vital signs, and any other pertinent observations. Finally, my recommendation would be for an immediate physician assessment, And depending on the clinical picture, I would anticipate and prepare for advanced interventions such as intubation, administration of emergency medications, or transfer to a higher level of care like the pediatric intensive care unit. Throughout this critical period, I would maintain open and calm communication with the parents, explaining the immediate need for rapid intervention while offering reassurance.
A child on your ward has just experienced a seizure. What are your immediate nursing priorities during and after the event? How do you document this?
When a child on my ward experiences a seizure, my immediate nursing priorities are sharply focused on ensuring their safety during the event, followed by thorough post-event assessment and management, all meticulously documented. During the seizure event, my paramount priority is the child's safety. I would immediately ensure they are in a safe position, gently lowering them to the floor if they are in a bed or chair, and clearing any nearby objects that could cause injury. Crucially, I would turn the child onto their side, into a recovery position, to maintain a patent airway and prevent aspiration, especially if vomiting occurs. It is vital to remember not to restrain their movements or place anything in their mouth, as this can cause harm. Simultaneously, I begin timing the seizure precisely from its onset, while meticulously observing and noting its characteristics, the exact movements of their body parts, any eye deviation, changes in facial expression or skin color like cyanosis or pallor, the presence of frothing, and any incontinence. I would also immediately call for help from colleagues and notify the physician. After the seizure subsides, my priorities shift to a comprehensive assessment of their airway, breathing, and circulation ABCs. I ensure their airway remains patent, assess their respiratory rate, depth, and effort, and monitor oxygen saturation, administering supplemental oxygen if indicated. I also check their heart rate, rhythm, and capillary refill time. Following this, a thorough neurological assessment is performed to determine their level of consciousness, pupillary response, and the duration and characteristics of the postictal state, noting any drowsiness, confusion, or lethargy. A full set of vital signs, including temperature, is obtained, and any necessary hygiene is provided if there was incontinence. My aim is to safely guide them through recovery, reorienting and reassuring them as they regain consciousness, and identifying any potential triggers for the seizure, such as fever or hypoglycemia. Documentation of a seizure event is critical and highly detailed. I would record the exact date and time of the seizure's onset and its precise duration. A comprehensive description of the seizure activity is essential, including the type of movements, e.g., tonic, clonic, tonic-clonic, focal, the body parts involved, eye movements, any changes in skin color, presence of frothing or incontinence, and any sounds made. I would also document the child's level of consciousness before, during, and after the event. All nursing interventions performed during and immediately after the seizure, such as positioning, oxygen administration, or suctioning, along with the child's response to these interventions, must be noted. Finally, I would record the characteristics and duration of the postictal phase, all vital signs taken, any injuries sustained, medications administered, including rescue medications, their dose, route, and time, the time and content of notification to the physician, and any communication with the family.
Explain the difference between consent and assent in pediatric care. When and how do you obtain assent from a child?
The concepts of consent and assent are distinct yet equally vital in pediatric healthcare, reflecting the evolving capacity of children to participate in decisions about their own care. Consent, in its legal and ethical sense, refers to the informed permission given by an individual who has the legal and cognitive capacity to make decisions. In pediatric care, this legal and ethical responsibility typically falls upon the parents or legal guardians, as children under a certain age, usually 18, depending on jurisdiction, are not considered legally competent to give full consent for medical treatments or procedures. This means parents receive comprehensive information about the child's condition, the proposed treatment, alternatives, risks, and benefits, and then provide their informed authorization. Assent, on the other hand, refers to a child's affirmative agreement to participate in a clinical procedure or research, even though they may not possess the full cognitive ability or legal standing to give full informed consent. It signifies a child's willing participation in their care, given their developmental understanding. Assent is built on the principle of respecting the child's developing autonomy and involving them in decisions that affect them within their capacity. I aim to obtain assent from a child whenever they are developmentally capable of understanding the information presented, typically starting around 7 years of age, though this can vary greatly depending on the individual child's maturity, cognitive abilities, and previous experiences. For a highly mature younger child, I might seek assent earlier, while for an older child with developmental delays, I might adapt the approach. To obtain assent, I employ several strategies. First, I use age-appropriate and child-friendly language to explain the procedure or treatment. This involves breaking down complex medical terms into simple analogies and focusing on what the child will see, hear, feel, and experience, and why it is necessary, e.g., this medicine will help your tummy feel better so you can play. I assess their understanding by asking them to repeat back in their own words what they've understood, or by observing their reactions. Second, I address any questions or concerns they might have patiently and honestly, without giving overwhelming details. Third, I emphasize that their agreement is important and valued, but also clarify that some treatments are necessary for their health, even if they don't like them. However, I offer choices whenever possible to give them a sense of control, e.g., do you want to take your medicine with water or juice? If a child expresses strong dissent, particularly through persistent refusal, fear, or distress, I pause to reassess. While their dissent doesn't legally override parental consent for necessary life-sustaining or highly beneficial treatments, it signals a need to explore their fears further, adapt the approach, or seek alternatives if medically appropriate, always striving to find a way to provide care that respects their comfort and dignity.
A 15-year-old patient with a chronic illness refuses a necessary treatment. How do you navigate this, considering their developing autonomy and parental rights?
When a 15-year-old patient with a chronic illness refuses a necessary treatment, it presents a complex ethical and practical challenge, balancing their developing autonomy with parental rights and the imperative to provide best medical care. My approach prioritizes understanding the patient's perspective, fostering open communication, and involving the multidisciplinary team. My immediate action is to establish a private, non-judgmental conversation with the adolescent to truly understand the underlying reasons for their refusal. It's crucial not to assume. Is it fear of pain, side effects, or the long-term implications of the illness? Is it a desire for more control over their life, a feeling of being overwhelmed, or perhaps misinformation? Could it be related to body image concerns, peer pressure, or the social impact of the treatment on their daily life? By actively listening and validating their feelings, I aim to build trust and uncover the root of their resistance. Once I have a clearer understanding, I engage in honest and transparent education tailored to their cognitive level. I explain the illness, the specific treatment, its necessity, and the potential consequences of refusal in a clear, straightforward manner, focusing on their long-term goals and quality of life. For instance, I might connect adherence to treatment with their ability to continue attending school, participating in sports, or achieving future independence. I also offer choices within the treatment plan whenever possible, such as scheduling flexibility, choice of arm for and for, or preferred medication administration methods to empower them and give them a sense of control. Simultaneously, I facilitate open communication with the parents. While parents hold the legal authority for medical decision-making for a 15-year-old, the adolescent's assent and active participation are vital for adherence and overall well-being. I would help the parents understand their child's perspective, guiding them on how to offer support and encourage compliance without resorting to coercion. It's about finding a collaborative path forward that respects the teen's burgeoning autonomy while upholding parental responsibility. If the refusal persists despite these efforts, I would engage the full multidisciplinary team. This involves the primary physician, who can provide further medical rationale and address clinical concerns directly with the patient and family. A social worker or child psychologist can be invaluable in addressing underlying emotional distress, mediating family discussions, and teaching coping strategies. If the treatment is life-sustaining and the refusal continues, or if there is profound disagreement, I would then escalate the situation to the hospital's ethics committee for guidance and resolution, always with the child's best interests as the guiding principle. My role is to be an advocate, an educator, and a facilitator, striving to bridge the gap between patient preferences and necessary medical care.
You suspect child abuse or neglect in a patient you are caring for. What steps do you take, and what is your legal and ethical responsibility in this situation?
When I suspect child abuse or neglect in a patient under my care, my immediate and overriding priority is the child's safety. This situation carries a profound legal and ethical responsibility for every nurse. My first crucial step is to ensure the child's immediate physical safety within the hospital environment. This might involve ensuring continuous supervision, or if the suspected abuser is the primary caregiver, taking steps to ensure they are not left alone with the child. Concurrently, I would conduct a thorough and objective physical assessment, meticulously documenting all findings using precise, non-judgmental language. I look for patterns of injury inconsistent with the stated mechanism, injuries in various stages of healing, or specific marks that might indicate abuse. Every bruise, laceration, burn, or fracture is precisely measured and described, and body maps or photographs are used if hospital policy allows and safety permits. If the child is verbal, I would conduct a non-leading, age-appropriate interview in a private, safe space, documenting any statements verbatim, understanding that deeper investigation is the role of specialized professionals. I also observe and document the caregiver's explanation of the injuries, noting any inconsistencies and their reactions to my questions. Reviewing the child's past medical history for previous unexplained injuries or frequent emergency department visits is also part of this comprehensive assessment. My legal and ethical responsibility as a nurse is paramount. I'm a mandated reporter. This means I have a legal obligation to report any reasonable suspicion of child abuse or neglect to the appropriate authorities. My role is to suspect and report, not to prove the abuse. Patient confidentiality, while fundamental to nursing practice, is superseded by this legal duty to protect a child from harm. The steps I take to initiate the report involve immediately notifying the attending physician, my nurse manager, and most importantly, engaging the hospital's social work department or child protective services (CPS) liaison. These professionals are experts in navigating the reporting process and will guide the next steps, including completing the formal report to the state's Child Protective Services Agency or law enforcement, as mandated by local laws. I would work collaboratively with the entire healthcare team, including social work and law enforcement, to ensure the child continues to receive appropriate medical care while the investigation proceeds. Throughout this challenging process, I maintain a professional and non-judgmental demeanor towards the family, focusing solely on the child's well-being and adhering strictly to established protocols, as the investigative work is not within my scope of practice.
How do you balance maintaining patient confidentiality with your duty to report concerns about a child's safety?
Maintaining patient confidentiality is a fundamental ethical and legal cornerstone of nursing practice, fostering trust and promoting open communication with patients and families. However, this principle encounters a critical and legally mandated exception when there are concerns about a child's safety, particularly in cases of suspected child abuse or neglect. In such situations, my duty to report overrides the standard rules of confidentiality. As a mandated reporter, I am legally and ethically obligated to prioritize the protection of the vulnerable child. This isn't a discretionary choice, but a professional imperative dictated by law to prevent harm. The balance is achieved not by compromising confidentiality entirely, but by recognizing that the safety of a minor is a public interest that takes precedence over an individual's right to privacy in these specific, legally defined circumstances. My process involves a systematic approach. Upon developing a reasonable suspicion of child abuse or neglect based on my assessment, observations, or information gathered, my immediate action is to follow established hospital protocols for reporting. This typically involves notifying my charge nurse, the attending physician, and most importantly, engaging the hospital's social work department or designated Child Protective Services (CPS) liaison. These individuals are specialized in handling such sensitive cases and are responsible for making the formal report to the appropriate state agency. It's crucial to understand that my role is to report the suspicion, not to investigate or prove the abuse. That responsibility lies with the investigative authorities. While informing the parents about this report is a delicate matter, it's often handled by the social worker or physician, or as per hospital policy regarding disclosure. My focus remains on ensuring the child's well-being and fulfilling my legal duty, explaining that my actions are rooted in my commitment to safety and adherence to the law. The information shared is limited to what is necessary for the report and the protection of the child, ensuring that confidentiality is breached only to the extent required to fulfill this paramount duty.
How do you support families experiencing the loss of a child on your ward? What resources would you provide? And how do you cope with your own emotions in such situations?
Experiencing a loss of a child on the ward is undoubtedly one of the most profoundly challenging situations in pediatric nursing, demanding immense compassion and resilience. My approach to supporting families during this unimaginable time is multifaceted, focusing on presence, practical assistance, and long-term resources, while also acknowledging and managing my own emotional well-being. My immediate priority is to create a sacred space for the family. I ensure they have privacy, often offering a quiet room where they can spend unlimited time with their child. My presence is calm and empathetic. I listen more than I speak, acknowledging their immense pain without trying to fix it. I facilitate memory making, which is incredibly vital for grieving families. This includes offering to create handprints, footprints, a lock of hair, or photographs, and ensuring the child is clean and comfortable for these final moments. I encourage parents to hold their child, even after death, guiding them gently through what to expect regarding changes in appearance. I also assist with practical matters such as gathering the child's belongings, offering to contact clergy or spiritual support, and providing clear, sensitive information about postmortem care and arrangements without overwhelming them. For resources, I ensure families are connected with comprehensive grief support. This includes providing information on hospital-based bereavement counseling, local and national grief support groups, and spiritual care services. I always have written materials on hand that outline these resources, offering pathways to support that extends beyond their hospital stay. Following discharge, depending on hospital policy, a follow-up call or card can also provide continued acknowledgement of their profound loss. Coping with my own emotions in such heartbreaking situations is a continuous process. I acknowledge that it's entirely human to feel sadness, grief, and sometimes even a sense of helplessness. Suppressing these feelings is not healthy. I rely heavily on debriefing and peer support within my team. Discussing the experience with trusted colleagues helps to process the emotions and normalize the intensity of our work. Outside of the ward, I prioritize robust self-care strategies. This includes ensuring adequate rest, engaging in physical activity, pursuing hobbies that bring me joy, and spending quality time with my own loved ones. If I find that personal grief becomes overwhelming or impacts my daily functioning, I do not hesitate to seek professional counseling. Ultimately, I reflect on the privilege of being present with families during their darkest hours, understanding that while I cannot erase their pain, my compassionate care can offer a small measure of comfort and dignity during an incredibly vulnerable time.
How do you explain the concept of death or loss to a young child, e.g., a 5-year-old, whose sibling has just died on the ward?
Explaining the concept of death or loss to a young child, particularly a 5-year-old whose sibling has just died on a ward, is one of the most delicate and emotionally challenging conversations in pediatric nursing. My approach is always rooted in honesty, simplicity, and compassion, creating a safe space for their grief. First and foremost, I ensure the conversation happens in a calm, private, and familiar environment, ideally with a trusted parent or caregiver present. I begin by using direct and concrete language, avoiding euphemisms like passed away, went to sleep, or lost, which can be confusing and frightening for a literal thinking child. I would state clearly, yet gently, your brother's body stopped working and he has died. He won't breathe anymore, and he won't wake up. This directness helps prevent misinterpretations and allows the child to begin processing the finality of death. I then allow space for the child to ask questions, no matter how simple or complex they may seem. Their questions often reveal their understanding and fears. I answer them truthfully, without overwhelming detail, and with consistent messaging. For example, if they ask, "Will he be cold?" I might respond, "Yes, his body is not warm anymore." If they ask, "Will he come back?" I would gently but firmly state, "No, when someone dies, their body stops working forever, and they don't come back." Throughout the conversation, I emphasize that it's not their fault. Young children often engage in magical thinking and may believe their actions or thoughts caused the death. I explicitly reassure them, "You did nothing wrong. This wasn't your fault." I also validate their emotions, explaining that it's okay to feel sad, angry, confused, or even to not feel anything right now. I might say, it's very sad when someone dies, and it's okay to cry if you feel like crying, or to be quiet if you need to be quiet. I also involve parents in this process, guiding them on how to communicate with their child and reinforcing the message. If appropriate, and if the child expresses a desire, facilitating a final goodbye with their sibling can be very therapeutic, allowing them to see their sibling and begin their grieving process. Finally, I connect the family with resources like child life specialists, bereavement counselors, and grief support groups, recognizing that this is just the beginning of a long journey of grief and healing. My role is to offer sustained support and a consistent presence as they navigate this profound loss.
Describe a time you collaborated effectively with a child life specialist or a social worker to improve a patient's outcome.
I recall a particularly challenging situation involving a 9-year-old patient named Liam, who was admitted for a prolonged course of intravenous antibiotics to treat a severe osteomyelitis in his leg. Liam was naturally very active, and the extended hospitalization, combined with the discomfort of his condition and the constant floor access, led to significant emotional distress. He became increasingly withdrawn, refused to engage with nurses or his physical therapist, and his anxiety about daily dressing changes and floor flushes was escalating, impacting his compliance and overall recovery. Recognizing that his emotional state was directly impeding his physical healing, I initiated a collaboration with our hospital's child life specialist, Sarah, and the assigned social worker, Mr. Raj. My goal was to provide a holistic approach to address Liam's psychosocial needs and improve his engagement in his care. I first spoke with Sarah, outlining Liam's withdrawal, anxiety, and refusal to cooperate. Sarah then spent time with Liam, observing his play and interests, and learned he was a huge fan of superheroes and building blocks. She developed a personalized play plan that integrated his medical care into his interests. For instance, she introduced superhero training exercises disguised as physical therapy, using building blocks to create forts he could navigate with his crutches. During floor flushes and dressing changes, Sarah would engage Liam in guided imagery, having him visualize his superhero cells, fighting off the infection, or distracted him with interactive games on a tablet. Concurrently, I discussed Liam's case with Mr. Raj, the social worker. He helped to facilitate crucial conversations with Liam's parents, who were also feeling overwhelmed and helpless. Mr. Raj provided them with coping strategies, connected them to parent support groups, and helped them navigate resources for school liaison during Liam's prolonged absence. He also helped manage communication between the parents and the medical team, ensuring they felt heard and supported in their child's extended hospitalization. The impact of this collaborative effort was remarkable. Within days, Liam's demeanor visibly improved. His anxiety during procedures decreased significantly, and he began to actively participate in his physical therapy, often laughing and engaging with Sarah. His parents reported feeling more empowered and less isolated. This holistic support directly contributed to Liam's improved compliance with his medical regimen, fewer reported pain episodes, and ultimately, a smoother and more timely discharge, allowing him to return home and resume his superhero training in a familiar environment. This experience truly underscored the power of interdisciplinary collaboration in achieving superior patient outcomes beyond just medical treatment.
How do you manage disagreements or different clinical opinions with a physician regarding a pediatric patient's care plan?
Navigating disagreements or different clinical opinions with a physician regarding a pediatric patient's care plan requires a professional, respectful, and child-centered approach. My primary goal in such a situation is always to ensure the best possible outcome for the patient, which hinges on clear communication and collaborative problem-solving. Let me recall a situation involving a 7-year-old patient named Lily, who was admitted with recurrent asthma exacerbations. Dr. John, the attending physician, proposed a rapid discharge plan after a single day of stability, focusing on oral steroids and a quick follow-up. However, based on my observations of Lily's respiratory efforts still being slightly increased at rest, and her mother, Mrs. Sharma, expressing significant anxiety about managing a potential relapse at home, I held a different clinical opinion regarding the optimal discharge timing. My first step was to gather all relevant objective data to support my assessment. This included Lily's respiratory rate trends, oxygen saturation readings, lung sound assessments, and her subtle signs of continued work of breathing, even if her overt wheezing had resolved. I also noted Mrs. Sharma's verbalized concerns, and her history of managing previous exacerbations, which had sometimes required readmission. Next, I approached Dr. John privately and respectfully, choosing a time when he wasn't rushed. I began by clearly stating my concern, using a non-confrontational and collaborative tone. I might have said, "Dr. John, I wanted to discuss Lily's discharge plan for a moment. While she certainly made great progress and her wheezing has cleared, I'm still observing some subtle increased work of breathing at rest, and Mrs. Sharma is quite anxious about managing her at home right now, given past experiences. My clinical assessment suggests that another night of observation might be beneficial to ensure her stability and to better equip Mrs. Sharma for home care." I presented the objective data I had collected and highlighted Mrs. Sharma's specific concerns. I focused on the potential risks of premature discharge, such as a rapid relapse and subsequent readmission, emphasizing how a brief extension could prevent a more serious outcome. I was prepared to articulate my rationale clearly and concisely, linking my observations directly to potential patient safety issues. Dr. John listened attentively, and after reviewing the charts again and considering the mother's anxiety in light of her history, he agreed to extend Lily's admission for another 12 hours of observation. During that time, Lily did show further improvement, and Mrs. Sharma felt much more confident in her ability to manage Lily's care at home. This collaboration ensured Lily's optimal recovery and prevented a potential readmission, all while maintaining a strong, respectful professional relationship with the physician.